now invite Dr. Ravi for his talk on visual fields.
Good afternoon, everyone. I'm Dr. Ravi Daruka from Sharpsight Eye Hospitals, Asansol, West Bengal. Today I am going to talk about glaucoma, visual fields in glaucoma. And in this, I am very thankful to AIOS to present me with this opportunity to talk today. So what is visual fields? Simply put, it's everything we see simultaneously while we fixate our gaze in a particular direction. And glaucoma causes defects in this visual field because of particular patterns of RNFL defects. It causes particular patterns of visual field defects, and we need to recognize these defects as early as possible and start treatment with minimal damage to the visual field, which is our main agenda. So why do we need to assess visual fields in glaucoma? First of all, we know reduction of visual field reduces the quality of vision for life for the patient and hinders daily activity. And progressive field defect is the most definitive proof of glaucoma. Also, measuring visual fields help us to set treatment IOP targets according to the severity, and also helps to in disease tracking. So this is how Trequard described visual fields as a classic island hill of vision in a sea of darkness. This hill has a peak, which is the foveal sensitivity, and then a smooth contour as we go towards the periphery. And it's measured by kinetic and static perimetry, but static perimetry is what has become the gold standard nowadays. Humphrey field analysis is the gold standard, and what we shall focus on. It involves stimulus presentation to the patient and recording of these responses of the patient to these stimuli, which is a standardized procedure. The initial test detects and quantifies the damage, while the follow-up test detects stability and progression of the glaucomatous damage. The stimulus size, intensity of light stimulus, and the algorithm for testing all are very standardized. These are the common testing patterns we use normally. Today, mainly what we are going to discuss is the interpretation of a Humphrey visual field, the pattern recognitions in glaucoma and non-glaucomatous visual field losses, and common mistakes which we may avoid. This is how a single field print analysis looks like, and for ease of interpretation, we divide it into 10 zones. The first zone is the patient data and test data. The name of the patient, the age should be correctly entered, and the testing condition should be proper with a proper pupillary diameter of at least 3 millimeters. And the refractive error of the patient should be correctly entered. The correct lenses should be provided to the patient so that we don't make errors during the test. Also, the second zone is the zone of reliability. And here we need to see that the patient does not give any high fixation loss errors or high false positive or negative errors. Also, we need to be sure about the fixation target, which should be central in a normal patient, but if there are cases of macular scars or something, we need to change the target to a small diamond or large diamond. Also, the fixation monitor should be on so that we know that the patient is not moving his eye. There are some technician faults also which may lead to a loss of reliability of the field, like if the patient's age is not entered correctly or the refractive error is not given to the patient. The pupil size of less than 3 millimeter will produce unreliable fields, and even not properly positioning the patient's head will lead to unreliable fields. The fixation targets, as I said, should be proper. The gaze tracking should be on, which helps us to track whether the patient has closed his eyes or he has moved his eyes. The blind spot fixation monitoring method helps us to know the same too. This is how a high false positive test may look like, where the patient is a trigger happy patient and he's keeping on pressing the button in spite seeing no stimulus, and there are white scotomas present here. A false negative test would look somewhat like this, where there's a clover leaf pattern here because of the algorithm tests in some particular points in particular times. The central points are tested where the patient was doing the test correctly, but as the test progresses, he probably sleeps or he's fatigued, and then he produces a false negative result. The third and fourth zone are the raw data and grayscale data, which are used to derive the total deviation numerical plot. Here, the raw data of the patient is compared to the age-related normative database, and the deviation at each point is calculated by the machine. Then the machine derives the pattern deviation numerical plot. In this, it adjusts for the general reduction of the sensitivity of the field of vision. The general height of the vision is reduced, and the 7th best sensitivity point is taken as 0, and the other points are adjusted to give a pattern deviation plot, which gives us the more localized field effects which we see in glaucoma. So then there are the probability plots, which gives us a visual representation of how likely the point is to be within the normal limits or outside. So for example, if we see the solid square, which says P value of less than 0.5%, it means that's only a 0.5% chance or less for that point to be normal sensitivity, and there is more than 99.5% chance that the field tested point is abnormal in this patient. Then the zone 9 indicates the global indices. Here there are a single number tries to give an overall idea about the field of the patient. The hill of the height of vision, how far it's reduced is given by the mean deviation. The pattern standard deviation gives an idea about the localized effects, and the visual field index, it helps us to determine as a percentage of the normal, the patient's visual field, the present visual field as a percentage of the normal for his age. This is how a localized field defect would look on the traquear's field of the hill of vision. Here the localized effect affects the contour of the field of vision, the hill of vision. Here the pattern standard deviation will be high, mean deviation will not be affected much. In a generalized field depression, the mean deviation will be high and the pattern standard deviation will be low, because there are no localized defects as such. The general contour of the hill is maintained. And in patients with localized with generalized field effects, there will be both high pattern standard as well as mean deviation. So the 10th zone is the glaucoma field test. We know in glaucoma the field is affected, the hemifields are affected asymmetrically. So one hemifield is tested against the other, and the machine analyzes whether the two fields are symmetrical. Usually in glaucoma it will be outside the normal limits. So we can use the Anderson's criteria to diagnose if the field is glaucomatous or not. And we need to definitely repeat the fields, because during OHTS follow-up, up to 86% of the visual fields on testing, on repeat testing, came out to be normal when it was abnormal of the first test. So usually glaucoma field effects will be asymmetrical across the horizontal meridian, located between 5 to 25 degrees in the mid-periphery. They correlate very well with the disc and RNFL changes, but we need to rule out other ocular causes of field effects in the retina or other places. We then need to categorize the fields into early glaucoma or moderate or severe field effects. And so first of all, we need to see whether the field is reliable or not, and then we need to categorize it into localized or generalized defects. And if it's generalized, then whether it's a uniform generalized or it's a generalized with localized field effect. The common patterns of glaucoma defects which we see are nasal step, a temporal wedge defect, superior or inferior arcuate defects, paracentral scotomas. Then in the more advanced cases, there could be tunnel vision or complete loss of vision. There are non-glaucomatous neurological field defects and others which may present, a papilledema may present with an enlarged blind spot. As in this case, a left homonymous hemianopia may be present in a patient with stroke. There may be a bitemporal hemianopia in pituitary tumor patients. Central scotoma may be present in central macular scars, and an upper eyelid ptosis could cause a superior arcuate kind of defect, and so on. There are a lot of other conditions which could cause glaucomatous field defects, like Drusens, optic nerve head Drusens, tilted optic nerve, AION, etc. And we need to also avoid certain mistakes. Like I said before, a pupil size of less than 3 millimeter will give a false impression of a peripheral constriction of fields, which when repeated with the correct size of the pupil size, the peripheral constriction goes away. Patient with a -7 diopter refractive error, when not given the proper correction, will show a generalized depression like this on a total deviation, but not on the pattern deviation. But as soon as we give the correct refractive correction, the field becomes normal. Also, high fixation loss errors will result in very erroneous fields, which when repeated with less fixation errors, the field defects are shown to be much less. There are certain glaucoma mimickers which we should be wary of, and like an optic disc pit can give rise to a superior arcuate kind of field defect. We also need to be aware that a glaucomatous patient may further come with a neurological field defect simultaneously. Like in this patient, the patient has a pre-existing superior arcuate defect here, but now he has developed a inferior quadrantenopia due to a recent stroke. And also we need to be aware of the general appearance of the patient, like a blepharotosis could give rise to superior arcuate defect like this in this patient. And so to summarize, the basis of treatment, visual field assessment is the basis of glaucoma diagnosis and treatment, and it involves a systematic approach to the field analysis printout. The field analysis has to be labeled as glaucomatous or not according to Anderson criteria, and has to be categorized into early, moderate or severe defects, which help us to determine the treatment IOP targets. And we need to further identify it from glaucoma mimickers, and correlation of the fields with the clinical condition is a must. Thank you.
Thank you, Ravi.